Today we'll be taking how to take history in a child. By the time you're here, you had your posting in general medicine, general surgery and OBG. So you know medical history taking. Here we'll be discussing only the salient difference in the history taking. First, we'll be asking name and age of the patient. It is the same as adult. One important point is there is a need for an informant. I'll just cover the major points, then elaborate again one by one. The presenting complaint, history of presenting complaint, then past history, and then comes a unique points in a child. Antenatal, natal, postnatal history in a continuum, followed by developmental history, nutritional history, which is relevant for an adult also, it's more important in a child. Immunization history, nowadays more and more importance is given for vaccination in adult, but all these years immunization was mainly the main for child. Socioeconomic history is another one. It's as usual we are taking the socioeconomic history in the adult. One point, we are taking personal history in an adult. We are not including personal history in a child. So, we'll come to the points one by one. Now, name, age, sex. What is the peculiarity of name? In a child, most of the situations will have a name, but in a newborn, the name is yet to be given in our culture in Kerala. So, most of the cases, baby of Janaki, baby of, like that. And an older child, maybe after 1-2 months, their own name. What about the age? All of us know in an adult, age in completed years. But in a child, previously we were considering day of birth up to 12 years. Now, adolescence also is coming under our pediatrician's territory. Long years, this adolescence group were no man's territory. It's nor pediatricians or adults. Now, pediatricians take the responsibility to treat and care the adolescent group up to 19. So, now coming to the age, on all the older age group, we'll give completed age. But we need to consider a young child below 1 year, you call it age in months, 8-month-old baby, or maybe 1 year and 8-month-old baby. So that's about months. It can be in days also, because neonatal period is a period from birth to 4 weeks, maybe first month. So you divide the period as newborn period, and beyond that up to 1 year called infancy, and then toddler up to 3 years, then after that child, adolescence, like that. So newborn period, it's not in months, age in days matters. It's an 18-day-old baby Janaki, like that. Is that days? Some situations even the hours matter. A baby born 36 hours back developed dyspnea. So that's very important, because there are certain problems which have an onset starting from hours. Imagine a ductus closes, and ductus usually closes, patent ductus arteriosus, and you have heard of foramen ovale and this ductus which is essential part of the fetal circulation, it naturally closes. But some situation, this is essential for the survival. The baby starts deteriorating the moment the ductus closes. So a very important clue, the time when he deteriorated. We call it as ductus dependent pulmonary circulation, ductus dependent systemic circulation. So it's the hours of onset of the disease after the delivery. So when you talk about the age in a child, you need to consider hours age, days, months and the years. Unlike in an adult where it's always the completed years. About the sex, nothing more to add. Always you need to consider there's a male, female, there can be in the newborn babies, transgender, what do you call it? The disorders of sexual differentiation. Sometimes you may not be able to categorize as a male or a female. And it's a very important thing is, unless you are sure, we are not supposed to disclose the sex. It's an emergency because there can be some problems also associated with that. Okay. There is a third group which you need to consider. So, those things about the name, age and sex. There is one more very important point there, that is, this is the informant. In an adult, most of the situations you get the history from the patient. Provided is okay, he's well, he can give the history. Provided his mentation, he's not having any mental illness. Is comatose patient and a psychologically disturbed patient. You cannot deaf and dumb patient. You cannot get the history from him. You need another person to give the details. In a child also, it's not always. Sometimes you can get the similar history from an older child who is intelligent. Maybe after 6 years, 7 years, he may be able to tell most of his own complaints. That's very, very important because he can only tell his own problems. So you need to get the history from him as far as possible. Of course, he may not be able to give the entire details. You need to depend on the parent also. But the younger child, you need an informant. So the details of informant is relevant when you talk about the history because how much reliable is the information about him? Most of the cases, the information you are getting from the mother or father. They again don't think that the history given by the mother, father or the closer parent need be reliable. It need not always be. The mother may be an employee, may be visiting once in a week, coming to home. He leaves at 6 o'clock, returns at 7 o'clock. So that situation, she may not be knowing the entire details of this child. There the grandmother or whoever is looking after this child throughout day in, day out is a better informant. So there are situations like that. It may be the other way also. Sometimes mother is not there. It's the grandmother accompanying because mother is having a younger child. So you need to mention that point. Who is the informant? How reliable the informant is. So here, even the closest parent relative need not be reliable and grandparents may be reliable. The other situation also, the informant is given by the grandparent, but it's not reliable, the mother is not there. Both the situations. So you give value depending upon the situation. Sometimes you cannot give any value. You need to depend only on the examination findings. And now comes the presenting complaints. Just as you take the presenting complaint in an adult medicine, surgery, OBG, wherever, the main complaints in chronological order. Main complaints in chronological order. That means first problem occurred first. Fever 2 weeks, cough 10 days, and for the last 4 days he is having dyspnea. 1, 2, 3, maybe 4. You need not include the entire complaints in this presenting complaint. Main complaint which made the patient come to you. There may be multiple complaints, but you can include those complaints when you talk more in detail in the history of presenting illness. Here, there's a catch. Unlike an adult, there may be a situation where this child is now brought here not for any complaint which recently occurred. He is brought here for evaluation of, he is not performing as his peers are doing. He is not attaining developments as expected. So a development delay or some other problem which is not starting now. So what is a presenting complaint? Is there a need for presenting complaint of short duration then? Maybe a situation like a long duration development delay now comes with a cough fever and aspiration pneumonia like that. There you can present in two ways. One, you can elaborate on the presenting complaints like the fever, cough, dyspnea for the last 3 days, and actually this is not the major point. The whole problem started long back, and this is just one episode, and there were similar episodes many times. There's not much point in elaborating too much on these 3 days. You can say, as the problem started long back since birth, I would start from the birth. There is no problem at all. Only thing is that you need to elaborate in detail starting from the birth. Maybe even start from the antenatal period. Nobody will blame you if the entire history is narrated starting from that period. Only thing is if you are not missing any of the important point. It's an elaborate history. The basic idea of history is not to miss any of the important points. That's all. You're free to present this way or the other way also. You can present a complaint, presenting complaint, and next step, past history or antenatal history or break. So both ways are acceptable. Now comes the history of present illness. Again, you must have presented the thing, history of presenting illness in the adult medicine. This is the main part of the history. Very important, because basic idea of your history examination, what is it? You should have a provisional diagnosis. You are planning the investigation. Is there a need for investigation at all? Can you tell the diagnosis at the end of your history and examination? If that is the situation, you are a best clinician, doing least number of investigations, and you are confident enough to have the final diagnosis without any investigation. If not, you may be able to say possibilities, 4 or 5 possibilities, and you have excluded many by clinical examination history itself, and you need to narrow down from 4 or 5 situations only, and the lab investigations you are doing is just narrow down to minimum. You are not going to ask him to do this, that, and waste your money on investigations. So that's the very purpose of your clinical examination. So at the end of the history, you will have maybe 10, 15, 20 possibilities. And with that possibility, you start general examination. And at the end of general examination, you further narrow down the possibilities. Or maybe your possibilities considered at the end of history may be totally different at the end of your general examination. There again, few possibilities. Then you decide which system or which systems to be examined. And at the end of system, you come out with the provisional possibilities. What I was talking in short, history of presenting complaint is one of the most important part of the history. It is not just writing down what the mother says. It's not just writing a paragraph. It is the systematic analysis, taking the problem, going in depth of the problem, analyze the problem, postulating different possibilities, thinking this way, that way, this is the most likely thing, this is the least likely thing, Like that you are analyzing the problem in your mind when you hear. Let the person talk, and maybe a little bit of twisting when the patient is he's talking too much unwanted things, description of the hospital, talking too much of the doctor. We don't want that. You are going to analyze the problem as such, and again what somebody else has told about the illness. Doctor's impression is not important. Again, you need not check the document given by the doctor, discharge card. You read first and go. You will be biased. Going through the discharge card or whatever details is important only when the patient is unstable. You don't have time to go in depth about the case history, examination and all. You need to come to a diagnosis fast. There you can make use of all these documents. Otherwise, better avoid all those documents and you start the history and take the history, go in depth. So in short, what all things are the history? It should have an onset, detail of the onset, and how it progressed over days. Onset and progression. Maybe it remain like that. It can be varied form. It can be static. It can be waxing and waning, and it can, one of these complaints which started may disappear, another may appear, and this also may disappear, new things can appear, everything can persist. There are varied forms this can. So you need to go in depth about day 1, day 2, day 3, like that. What happened to this complaint on day 1? So go in depth about history, and maybe with the treatment start at the hospital, lot many things, hospitalization, yes or no, at that where was hospitalized and what happened and what is the sort of treatment, and maybe it's coming down and recovery. So what is the status now? Present status. So onset, evolution, course and progression, and treatment details and what happened in present status. The entire thing together is important when you talk about history. And day by day, the evolution of the problems, newer and newer problems should be there. And each moment you are analyzing the possibilities. And the details of the treatment also is very important. The history of presenting illness is very artistic. It's a blend of an art and science together. So you need to go in depth about each of the complaints. A fever coming, what all things are the, what is the nature of the fever at the beginning, after some time, how it evolved, whether it was persisting, many things. When we take history of a patient, you will know each patient history different. So it should never be just a small paragraph and writing down what the mother says and just move on. No. This is such an elaborate history point, and from which you will have some idea about what exactly and what it is not. So history of presenting illness, detail is very important. And then about the past history. So when you take a past history in an adult, you always mention certain things. No history of diabetes, no history of hypertension, no history of syphilis, no history of tuberculosis. So these few points you routinely mention a case of past history. Why you are asking about these illnesses in an adult? It's relevant definitely in an adult. Why? Because these diseases are chosen because these are diseases which are relevant in whatever illness in an adult. So there is no system which is paid by these entities. Diabetes, hypertension, syphilis, tuberculosis, and few of the other entities are well known to produce anything which you read in medicine. So if you think about eyes, iridocyclitis, there can be relevance for this thing. You think about ovary, there can be relevance. You think about stomach, there can be relevance of any of these. So they can produce illness, pathology in any system. That's why routinely we ask these entities. But for a child, the disease processes or pathologies are a lot different. These illnesses may be relevant in a few cases, but not in all cases. So, routinely we won't be mentioning about these entities when you take past history in a child. So, what are the past history points then? Relevant past history. There is no tailor-made points. Relevant past history. For example, puffy eyes, oliguria, reddish discoloration of urine. You need to ask about past history of pyodermas, authored because acute nephritis. It's a case of pneumonia. You need to ask past history of recurrent pneumonia situation, recurrent respiratory events, past history of aspiration. So, relevant past history. There again, past history of contact with tuberculosis. So, depending upon the problem, you need to think and related things you need to ask. Now, a child is coming with weakness of both lower limbs, gradually progressing from lower limb upwards. GBS is possible. You need to ask about viral infection, fever, skin rash a few days back. He was on a vaccine, was on an anti-sera, he was on some other drugs. So, relevant points in the past history. Many of the illnesses, there can be repeated episodes of similar illnesses. Pneumonia, there can be repeated episodes. Asthma, there can be repeated episodes. A cardiac problem, there can be repeated episodes of pneumonia. And there can be congestive failure. So, relevant points based on what is the complaint. Then, now comes the important history which is not there in an adult. This is antenatal, natal, postnatal history. We all know a beginning of a person is not from the point when you are born. No. Your beginning is at the time of fertilization. And there are a lot of developments which are happening in utero which can have a bearing on your lifetime. All of us know the cell stages, the bilayer, trilayer and the folding, and organs are all formed almost by the end of first trimester. Organogenesis occurs and maybe a little into the second trimester also. So any problem happened during this period can lead to many malformations. The basis of malformation is either the problem with the seed, genetic problem, or the first part of the intrauterine environment, the environment leading to damage to the organs. So we need to ask about bad influences on the baby during this period. What are the usual ones? Intrauterine infections, drugs, radiations, and many other things, maybe including trauma also. But most important ones which we need to consider are the intrauterine infections. There are many intrauterine infections. The classical one is the rubella, which all of us know, toxoplasmosis, cytomegalovirus, herpes, syphilis, and later HIV, and many other infections sometimes can lead to damage the fetus. We have thought of COVID also, whether it is producing any major malformation. Not much malformations, a little bit on prematurity, some other subtle problems during COVID. But many of the other infections in intrauterine, if it is happening in the first trimester, rubella is the well-known one, producing damage to eyes and ears and the brain and the heart. Toxoplasma predominantly produces the damage to the eyes, the brain. Heart is somewhat spared. Like that, the different infections which occurs can have a damage in different ways. So how can you elicit that history, whether it was just because it happened long back when this baby was in utero and now the baby is now 8 years, mother may not remember. What all things will you ask to elicit the possibility? So you need to ask the common factors for all these things? What are the common things? You need to ask whether there was fever during the first trimester, whether there was any rash. There can be maculopapular rash in toxoplasma, rubella, cytomegalovirus, and in varicella also something very, very important which can have a bearing that occurs usually in the second trimester. Herpes also, vesicles like. So maculopapular, vesicles, some other rash you need to ask. All of us should be taking varicella vaccines and the rubella vaccines. All the medical students, be careful. Don't omit these vaccines. Very important, varicella, you need to elicit this history. Okay. What about the drugs? Ideally, no drugs are needed, not even vitamins. During the first trimester, avoid all unwanted drugs. All of us know thalidomide tragedy, and those people are taking anti-epileptic drugs, Dilantin sodium, but it's fetal Hydantoin syndrome. That can be there in sodium valproate, other anti-epileptics also. So, be careful when the epileptic mother, what drug she is taking, you need to ask. There are many drugs your anticoagulants can produce. There can be fetal alcohol syndrome, many damaging things. Though better avoid drugs. You need to ask about the drug taken for illness during the first trimester. And of course, radiation. All of us know the Second World War problems in Hiroshima bombing and all. So that can lead to long-lasting influences on the child, lot of death, and later the chances of malignancy, malformations, everything. Nowadays, you need not worry too much about that thing, but the radiations, lab diagnosis, the conventional X-ray may not be that dangerous, but when you're taking CT scan, it's very important. There's many times of a safe level. And barium, barium enema, barium meal, CT scan, MRI is safer. So you need to ask about that investigation the first trimester. So those are very, very important ones, because first trimester, any insult, you may not get the history. Still, if you are getting a unique features of this intrauterine infection, you need to consider that possibility always. What about the second trimester? I said at the end of the first trimester, actually the baby's size is in grams, just a few grams only, a few centimeters only. And uterus is yet to come to the pelvic level. It is still inside the pelvis. So second trimester, it comes out of the pelvis, it starts to become palpable. And what about the second trimester baby? Second trimester, growth in length happens, not much of growth in weight. So by the end of 28 weeks, somewhere around 1 kg weight of the baby. So all of us know by the end of trimester third, term baby will be having 3 kg. Second trimester end just 1 kg. What all things will you ask in this second trimester? You can take two things. One thing, you need to assess the well-being of the baby. There is something very good, interesting point which happens in second trimester. The baby's heart, sometimes heart sounds can be heard, but not by the mother. A physician, OBG person can listen to the heart sound. Second thing is the kicking. Mother perceives the kicking of the baby. So you can ask whether the kicking movements of the baby is perceived, and movement should be perceived normally. That can be asked. And whether the abdominal girth is normally happening, that is assessed by the doctor. Mother also should feel that the uterus is going up and everything is fine. And the second thing is the bad problems, unique for the pregnancy, certain points, very, very important. There are three things. One thing is hypertension, pregnancy-induced hypertension. Second thing is gestational diabetes, and some of the things, this bleeding manifestations. I forgot to mention few points when a pregnant lady comes to you for the first time. What are your responsibilities when a pregnant lady comes to you and UPT positive? She is first time coming and reporting to you that I am pregnant, that positivity. So you have got many responsibilities on that day. You are registering the pregnancy under your care, and you need to evaluate the mother, and your responsibility to see that at the end of 10 months, the safe mother and a healthy baby. That is your vision, it's your target. And for that, the planning should start on the day 1. So that is your responsibility. Register the pregnancy, and there is a system, HMIS. This is a mother and child tracking system is there. The number, babies number in up to 5 years of this babies, and mother card, mother child protection card are there. It's a book now. So the card start from the delivery period, but the tracking system start from the day of your the positivity. The baby is started. So first point is to ensure that this mother can carry the pregnancy normally till term. You assess the risk. The mother should not be having a significant medical illness like diabetes, like heart disease, endocrinological disease. A lot of things you need to consider, rule out. And you need to see the fitness of the mother, height, weight, BP, everything. That's your responsibility to risk stratification and say, okay, we'll proceed. There are some problems and you need to tackle that. All those situations you need to decide before moving. Baseline investigations like the blood grouping, hemoglobin, VDL, hepatitis B, those tests need to be done. Urine albumin need to be checked. Maybe the blood sugar, other baseline investigations also need to be done. All these are our responsibilities on day 1. So why I mentioned this is, and non-diabetic, non-hypertensive mother, during the second trimester there can be hypertension or diabetes. There is gestational diabetes and pregnancy-induced hypertension and the bleeding manifest. So these are pregnancy unique thing. There is one more thing, toxemia, preeclampsia toxemia. They start developing BP, hypertension, urine albumin, and maybe a little later it can lead to edema and eclampsia, something involving the brain, seizures, altered and some many grave situations. So it's a forerunner of the eclampsia. So you need to ask about all these things in the first trimester. So now you are taking the past history, but this, whether this event were there in that mother, because all these are going to affect our baby also. So if there was such a history, that is one reason why this baby is like this with the developmental delay now, because in utero his nutrients, his oxygen supply, everything was affected. So you need to take the history, what all things bad happen during the trimester. Okay. What about the third trimester? Third trimester is a time when the growth in weight happens. The 2 kg weight growth is happening during the last trimester. The placenta is responsible for transferring all the nutrients needed for that, and few more things are happening during this period where all the systems are getting matured. No malformations because organs are formed during the trimester, but the maturity of the systems are likely to happen during this period. So if there is a prematurity, there is a chance for the immaturity of the system. The weight gain and the maturity are the one things which are happening during this period. So there can be deficiency of transfer of the required things like immunoglobulins to the baby if the baby is delivered early. So lot many things are given by the mother to the baby during this period. Very important point which you need to consider during this pregnancy is there are lot many government programs for them. Whether they got all these things. Ideally, after the registration, we need to be monitoring the pregnancy every month in the first 6 months, later first trimester, the second trimester every 2 weeks, and last trimester every week. But at least 4 visits should be there. And during these visits, 2 major national programs is, one is anemia control program. The antenatal period iron and folic acid tablet. Not anemic, you need to give at least 100 tablets. Anemic, 200 tabs at least. So that should be given, and we need to immunize the mother with a TD vaccine, 2 doses of TD vaccine. If the pregnancy, if another pregnancy happened within 3 years, there is a need for one dose only. So you need to ask for that also. So those are the things to be considered about the pregnancy or antenatal history. Now comes the natal history or delivery details. Where was the delivery? Was it in a hospital or was it in a home? Hospital delivery 99.9% in Kerala. Hospital delivery. Rarely home delivery happens. That is usually happens without planning. Sometimes on the way to hospital, precipitous delivery. It's not because deliberate. Precipitous delivery which happens without the control. And some of the people conduct the delivery at home deliberately. That should be reported. Why should a natural phenomenon be taken to the hospital? That's a nature question. Definitely pregnancy and delivery are all physiological things. We need not disturb them. But what you are doing is not disturbing. What you are doing is let it happen under your vision. You are there to monitor each and every point, and you are intervening as and when there is a problem occurring. That's the reason why the delivery should always be in a hospital. It should not be happening in a home and not under your care. So if this happened, you need to ask why and what was the reason. And then, when was the delivery? Was it term? Was it happening earlier, pre-term? Was it happening post-term? No, term is beyond 37. And if it is earlier than that, is pre-term. And 42 weeks, more than 42 weeks is post-term. So normal term is 37 to 42. So we call it as 40 weeks, but anything completed 37, you call it as a term baby. It's a preterm baby. So there are lot many problems of a preterm. Preterm, the maturity of systems. All of us know the baby was kept in the warmer because temperature maintenance problem. Baby was ventilated. Baby was given surfactant because the lungs are not mature. Surfactant. So problems of the preterms are basically immaturity of the lung, immaturity of temperature regulation, immaturity of the liver leading to jaundice, leading to coagulation factor, bleeding manifestation, leading to infections because they didn't get the immunological elements in the full quota. So the preterm babies are unique. And post-term, delivery is not happening the usual time. And beyond some time, what happens? The placenta will become senescence. Old age happens to the placenta also. They won't be giving the nutrients transferring, oxygen transferring. The babies are likely to get hypoxic. They'll pass meconium in utero. Meconium stain, like baby will be having pea soup, like aspirating, leading lot of respiratory problems and complications. So post-maturity is not at all good. So both preterm and postterm are bad. Then come to the details of the pain. Pain, when was it started? When was the leaking started? When? Second stage, true stage usually happens somewhere less than 30 minutes to 1 hour is the delivery time, actual second stage. You need to know about the pain onset and the leaking, because if it is too much delayed, the leaking started, that delivery happened long time taken. That means the amniotic sac is ruptured and there is a chance of infection. So we need to ask how long back the rupture and leaking started. And one more thing, the number of PV examination done during this period, maternal fever, bad smelling liquor, all these indicate that bacterial contamination of the baby amniotic fluid has happened that can lead to fetal infections, baby's infection, neonatal sepsis. Very, very important. Then baby is delivered. What is the first thing? First cry should happen. Whether the baby cried immediately. All of us know the golden minute, the first minute in a lifetime that decides whether you are going to be normal or not. The first moment, first minute of delivery. If the cry didn't occur, it's bedridden child. It's the whole life will be dependent. You heard of cerebral palsy. So first golden minute, everything should happen. First breath is first cry. Was there any recitation needed? So recitation details you need to ask. Whether the baby was given to the mother, whether the baby was transferred to the ICU, lot many things about the baby. You need to ask about the weight. You need to categorize the weight into, and the categorization of the baby is term, appropriate gestation age. The weight may more than 2.5 is age A, term. More than 4 is LG, a large for gestational age. So anything less than 1.5 is called small. Small for gestation, low birth weight, and anything less than 1 kg is extremely low birth weight. This is very low birth weight, VLBW. VLBW. This is less than 1 is ELBW. You need to categorize the baby based on a maturity and the weight. Now comes the postnatal period, first 4 weeks of 1 month after delivery. Again, it's equally important because the maximum death of the baby happens during this neonatal period, first week. So this period is so important. You need to be vigilant about the common causes of problems of babies. Most important, of course, all of you know the respiratory distress. In a preterm baby, you know the HMD, hyaline membrane disease. In the postterm baby, you call it as a meconium aspiration. Many other reasons for the respiratory distress are there, maybe due to infections and pneumonia, maybe due to other reasons, many reasons. Any respiratory distress you need to detect. If the rate is more than 60 rate and many grunting respiration, and all these things you need to detect. Then about the seizures. Neonatal seizures due to many things, hypoglycemia, hypocalcemia, due to meningitis, IC bleed, many other things, you need to detect the seizures. That's it. All these are dangerous signs in the newborn. And color, it can be anything, can be jaundice, can be physiological or pathological, pallor, undue pallor, polycythemic, very red also is not good, blue, cyanotic, any bleeding manifestation in the baby, and not active, not feeding, sick child, sepsis. So all these things you need to know. So we have covered half of the history, and there is one more half you will cover in the next session.